Welcome, everybody, to our webinar. Very, very pleased to be back here hosting again this month. Today, we're going to talk about quadruple aim. This is part 4 of our series, Healthcare Costs, using costs and payment to measure and accelerate value. I am really looking forward. I see everybody's joining in here. And so many of you will know the routine already. So just going to ask, if you are joining us, please type into the chat. Please make sure that it's everyone, or your sign may show host and panelists. But everyone is what you want it to see. So make sure that you're clicking into everyone, and let's see the chat and see people joining in here. And if you have a poll showing on your screen, you should turn that off. We'll come back to the polls after. So please join in the chat. Let's see everybody joining in and letting us know who you are. And I think they're going to start to come in a second. Oops. No, they can't. How did chat get disabled? We need to open up the chat. What happened there? Uh-oh. We're not going to know. Yes, I can see Jillian, only you, but everyone, it says on our host, chat's been disabled. Well, that is very disappointing. We've never had that happen before. So we do know there are 130 people on so far, so we're not going to hold you back. Oh, there we go. Thank you, Julie Nichols is the first one in now that it's working again. Whoever just solved that problem. Thank you very much, Anne or Kaylee. Hi, Logan, Victoria Chavis from Algoma. Welcome. Good to have you joining us here. Valentina Cardoso, Jason Cable, Nisha Berry from Durham OHT. It's open now. Yes, thank you. Patrick Boyley, OCSA. Now we really see people coming in. It makes it so much more welcoming when we can actually participate in this together. Jim from Welland, Mary Lee Bull, Catherine Isaacs, Kendra Dumont from Algoma. Please make sure you're chatting into everyone so everyone can see you. Hi, Robin from Huron Perth area. Please continue to check in. Let us know who you are. My name is Walter Wojcicki, and I am very, very pleased to be hosting today's session. I will start with this land acknowledgement. I am speaking to you today from the University of Toronto, and for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, the meeting place is home to many Indigenous peoples from across Turtle Island. I am, and we are grateful to have the opportunity to work on this land. This week is a particularly poignant week in Canada as the Pope and the Papal group are visiting and thinking about our time with residential schools in Canada and the atrocities and the challenges that ensued and continue to be a burden both on Indigenous populations and I think a time for us to reflect broadly as a society about the long-term impacts and reparations that we need to be thinking about. So just keeping that in mind today as we share in today's event and thinking about the health of Indigenous people across the way. We like to begin with a poll, and I always find this great. We amazingly continue from time to time to attract new audiences, and so I am going to, oh, I see we've already got it up. Have you joined us for a webinar before? And 73% had said yes, and 27% knows it's a new event. So this is actually quite consistent, which is amazing to me, is that we continue to attract about a quarter of a new audience each time. We're actually just starting. I have some undergraduate students to see about our audience and the how often people are coming back and who's coming back. And so welcome to the new people. I hope today will be fun and exciting for you. And welcome back to our many repeat friends who have been joining us many, many times in the past. So without further ado, we are going to move on. Today, We've been talking about the quadruple aim for the last 3 months, and this is our 4th month. We've gone through patient experience, provider experience, patient and population health, and this week we are looking at the quadrant of cost, and that's our focus for today. And we're going to think about cost in terms of value of the other quadrants relative to what we're spending. So keep that in the back of our mind. We are going to think about cost as a performance measure and cost as a planning tool. And we're going to hear about some of the supports that are being provided to you Ontario Health teams from the Ministry of Health. We are also going to then think about Ontario Health's approach to value-based payment and episode-based payments that capture health and system value. Very, very pleased to have Ontario Health represented today. And then I'm going to talk a little bit at the end just about some of our work. We've been thinking about costs and using costs in the health system performance network for the past more than 10 years at an individual person level. So I'm going to talk a little bit about that and some of the things we've learned over time. Today's event, I will be the host to 3 very illustrious panelists. And first of all, we have Jillian Paul, who's Director of Integrated Policy and Planning in the OHT division from the Ontario Ministry of Health. Howard Baker is Funding and Allocation Lead from the Health Sector Models Branch for the Ministry of Health and has been thinking a lot about what do OHTs need in terms of data to support their work. How do we understand how health system spending is actually observed at the level of Ontario Health teams? It's a whole new way for us to think about cost and think about funding. And Howard's going to share some of the results that they've designed to support OHTs. And I think it's a really good opportunity to think about maybe suggestions or ideas or thoughts you might have on the future of funding for Ontario Health teams. I think Howard would be all ears on hearing about that. And then we'll break for a couple of Q&As so that we can ask those questions and have that discussion. And then Dov Klein, who's the Vice President, Value-Based Care for Ontario Health. And I've known Dov for many years, and his understanding of how we think about shifting attention and shifting the system towards a more system-oriented view away from provider silos, and how do we get people to use financing as a lever. It's a really important lever and one that Ontario Health has an opportunity to support the work of OHTs. So Deb's going to talk about some of their early ideas, current thinking. You're aware, I think, of some of the current funding that's available, and it'll sort of sets out a bit of a direction for the future. And Deb's going to talk about some of those ideas and engender, hopefully, a good discussion with all of you. So welcome to all. And so without further ado, I will continue to watch the chat, but I'm going to turn it over now to Jillian and Howard, and you will just tell me how much you want to talk and when you'd like me to advance the slides, and I'll do so. So welcome, Jillian, welcome, Howard, and go ahead, take it.
Thanks so much, Walter, for inviting us here today to talk about this, and really looking forward to the discussion. So we'll run through these slides, which many of you have probably seen a version of or heard me speak about before. So when we first introduced the idea of Ontario Health teams in Ontario, we were given the opportunity to outline what a mature state of OHTs would look like. And based on our own experiences in Ontario and that with which we were able to sort of glean from other jurisdictions, our intention was set that at maturity, each OHT would be held clinically and fiscally accountable for delivering a full and coordinated continuum of care to their attributed population. And while integrated funding is a core component of the vision for integrated care in Ontario, we know that changes of this magnitude can take time, especially when there are implications for how the system is funded, and especially when a global pandemic is sort of thrown in there. So we also know, though, that the funding framework in Ontario has not been designed to support this vision, the vision of OHTs. And we obviously want to move beyond this current state to a place where OHTs are able to support more effective allocation of resources, improved integration of care delivery, and also eventually be funded to support those things through an integrated funding envelope. So data around performance and expenses has really been, from our perspective, an important support and is the foundation that teams have needed to understand more about their populations and the dollars that they spend on them. And at a mature state, we know that integrated funding of OHTs across the province will create conditions to innovate, be more aware of their own performance to drive quality improvement, and be fully accountable for the healthcare dollars that they spend. So if we go to the next slide, please. This is, if you have very good eyes, you may be able to read this, but in 2019, in the guidance document that was presented at the time of Ontario Health Teams being announced and launched, there was, this is in the appendix, I promise it is, even though you can't see it on the slide. And what this does is it outlines 8 core components that we've referred to, if you've been listening to any of our webinars before, as the building blocks of the OHT model. And these building blocks, and what this graphic showed you, what this table showed at the time, was what we were considering to be the readiness expectations or the readiness criteria for each of those building blocks, as well as year 1 expectations, so where we wanted teams to get to, and then what our sort of end state vision of Ontario Health Teams should be at maturity. So for the building block around funding and incentive structure, really, when we look back at this table, the status of that building block really does show us that we have met those, what we had termed early on as year 1 expectations, in that individual organizations, individual health system providers are still being funded within their ongoing existing relationships, but that a single fund holder has been identified, and that single fund holder is receiving the implementation funds that the ministry has been providing, and using those to support OHT operations. And what we also know is that Ontario Health Teams have been given information about their populations, and as well as expenses data reports have been produced for all approved teams. So if we go to the next slide, so these data packages, and hopefully many of you that are on this call are familiar with them and are here today to hear about them and to get a bit more of an overview. The second data package, so a second sort of round of data packages, has been provided to all approved teams last year, and they had been enhanced from the first round of data packages based on information that we had received from teams as well as from stakeholders on things that OHTs would need in addition to what we'd already provided. So the data packages do include 4 quote unquote sort of reports. The first report is around population performance and utilization measures. And so these are really characteristics and demographic information about the Ontario Health Team's attributed population, as well as several performance indicators and measures. The second report is about the attributed population going all the way down to census dissemination area. So this was a new feature to provide more granular information to teams about where their attributed populations reside. And then the third and fourth reports are what we'll be digging into a little bit more with you today, and talk more about costs by care type or NHPG, as well as expenses information. So I would say one final thing is that a guidance document was developed and released a year ago, and is available on our website, and I can ask one of my team to maybe pop into the chat the link to that guidance document. And what the guidance document does is it really provides an overview, a detailed really walkthrough of the data packages, as well as responds to a few sort of common questions that we had been receiving about the data packages to date. It comes in French, and some of the content will be reviewed with you today, but if you're interested in other information about the data packages or other information about the first two reports that I mentioned that are on this slide, I would highly recommend that you take a look at that guidance document. So again, thank you. I'm going to hand it over to Howard now to walk through the next few slides.
Thank you, Jillian. Hello, everyone. So as Jillian just mentioned, the first of the two expenses reports, the Excel workbook, contains expenses information stratified by care type and health profile group, or HPG. So before I begin discussing the report, I would like to take a minute just to provide you with a very high-level understanding of what these HPGs are and how they are defined. Many of you already know this, but it's to be a good review. So using the Canadian Institute for Health Information's population group or methodology, or CIHI's POP group for short, each patient attributed to your OHT is identified and assigned to one of the 239 health profile groups, or HPGs. Using a hierarchical algorithm with some clinical overrides and 2 years of data, the final HPG assignment is generally based on the patient's most complex and clinically relevant health condition. For the purposes of these reports, the health profile groups and categories are used to assign expenses to your population. The 16 categories are the final roll-up of the HPGs based on similarities in information, such as acute, chronic, or mental health profiles, and severity. And as Jillian mentioned earlier, if you'd like more information about HPGs and CIHI's POP grouper, I encourage you to review the Ontario Health Team's Data Supports Guidance document. And now I'll discuss the first of the reports. Next slide, please. So given that as an OHT, you will eventually be fiscally accountable for your patient populations, we provided you with these expenses reports to give you a snapshot of how it costs to care for those patients who are attributed to your OHT. The first report, Costs by Care Type and Health Profile Group, is the Excel workbook that focuses on the healthcare expenses of an OHT's network across the spectrum of care, including total expenses and average expenses per HPG or category. As you can see, the report breaks these costs down by care type in each column. So you'll see, for example, inpatient care costs, day surgery, ER expenses, etc. You'll also notice that this report breaks these costs down by row into health profile groups or categories. Next slide, please. Now, each tab enables a user to focus on the data either by HPG category, or you can examine by viewing all HPGs separately. The summary review of this workbook shows the 16 HPG categories, along with the count of the number of individuals within your population that have been assigned to that row, that is, the specific HPG category. As you can see, the last row represents the data for the entire attributed population. Now, if you'd like to see a comprehensive view, if you click and see each of the individual HPGs, you can click on the Step 1 Show Detail button, and then the file will show you the list of all the HPGs and their associated expenses. So for example, there are 27 HPGs that roll up to major acute. So you can see here the first three. A full list of the HPGs and their descriptions can be viewed on the tab entitled Code Table. Next slide, please. Now, healthcare expenses for your attributed population are presented in 2 tabs. In addition to the 2 views, there are 2 tabs. The healthcare expenses per year for your attributed population are expressed as either total expenses in one tab or per HPG population in the other. In the total expenses tab, you can see, as I mentioned before, the counts of your attributed population for each row, either as an HPG category or the individual HPG, depending on which view you're looking at, and the total costs associated with that population count. In the per HPG population tab, which is not shown here, you will see the same table. However, costs are calculated as an average per person in each row. In other words, the average cost you see in this tab will represent the total cost divided by the HPG population count. Now, keep in mind that these data are not risk adjusted for age, sex, or any other potential determinants of health. Note that certain expenses are included within a specific HPG. They may not seem relevant to the HPG. For example, there are often oncology expenses embedded into HPGs that are not related to cancer. And this is a byproduct of CIHI's POP grouper, since it categorizes patients based on by their most clinically relevant HPG. All of the patient's expenses associated with other episodes of care that may not be specifically related to that HPG get rolled up into that HPG. Now, in order to help teams get a complete picture of all the health conditions that are associated with their population, as Julie mentioned, we provided a long list of health conditions in the Population and Performance Utilizations Measure Report. Next slide, please. Okay, so this slide, I wanted to illustrate an example of how you could take the workbook and drill down and do some exploratory work on specific populations. So from this workbook, you can filter out different HPGs or categories that you want to look at, and you can then compare the distribution of costs within that specific HPG to the overall distribution of costs within your OHT for your entire population. So the pie chart on the left represents the proportion of expenses by care type for all patients assigned to all the HPGs within the OHT. So the pie chart on the right represents the distribution for the specific population that you've selected. Now, when looking at costs by HPG, many teams have asked if they should first find the highest expense HPG and then focus on integration efforts for that condition. So our answer to this question is, it depends. As I mentioned on the previous slide, the challenge with HPGs and the POP grouper is that they don't paint a complete picture of each patient. As I mentioned, some of the health conditions can be hidden when you focus on a specific HPG at a time. For example, another example would be opioid use disorder could be hidden from the data if a person who uses opioids or misuses opioids also happens to have diabetes. So one way to address this is to select an HPG that you feel aligns with your target population. For example, frail elderly. So for this OHT, I chose to examine HPG dementia with significant comorbidities as a good starting point to examine costs associated with the frail elderly population. As it happens, this HPG is the highest total expense HPG for this OHT, and the patients in this group represent approximately 1% of the population attributed to this OHT, and yet they account for approximately 10% of the total expenses. Now, when examining these pie graphs, also keep in mind that these numbers are descriptive only, and they're not meant to be prescriptive. As I mentioned earlier, these expenses have not been risk adjusted, so some of the differences may be due to the fact that different proportions of age and sex occur between the overall population and the target population. So obviously, if we're looking at dementia with significant comorbidities, they tend to be elderly patients, more female, so that may account for some of the differences you're seeing between the two pie charts. So now when you look at the two pie charts, the obvious difference that we see is the cost associated with long-term care, which would make sense given this population. Now, again, that this is not to say that it's appropriate to apportion over half of the expenses to long-term care in order to serve this population. Rather, one might use this information to generate discussion around how might one allocate resources to this population within the context of an integrated care program. Next slide, please. So this second report is a PDF of which the top half is presented here. This document illustrates at a glance your OHT's expenses and the proportions of which are related to services provided within your OHT. In other words, the market share of your OHT. And these proportions are stratified by hospital care types. So in addition to giving you a sense of the distribution of expenses, similar to the left pie chart from the previous slide, it also reflects where the services are delivered to your population. So I want to highlight this last piece. So if we can go to the next slide, please. So a foundational element of the OHT model, as you know, is that patients can continue to access care anywhere in the province, regardless of which OHT they've been attributed to. It is entirely appropriate for a patient to travel outside, for example, of your OHT to receive care that they need. For example, a patient who needs to travel to a highly specialized physician not assigned to your OHT in order to receive treatment for a specific condition. So to help you understand where the patients attributed to your OHT are receiving different types of care, we've provided these OHT localization data and these part charts you see on the screen. So as an example, looking at the leftmost pie chart, we see that for this OHT, 52% of its attributed patients receive specialized physician care from providers assigned to its network. 7% were received from a different OHT, 6% from another, and 35% from all other OHTs. So each of these pie charts shows you your market share, and then the top 3 OHT market shares, and then the rest. So when you're looking at these charts, it's neither a good sign nor a bad sign that your attributed patients are accessing care at other OHTs, because as I said, patients are allowed to access care anywhere in the province, regardless of which OHT they belong to. So now I'm going to pass things back to Walter to facilitate the next part of the webinar. But first, I would just like to take an opportunity to give a shout out to my colleagues, Kevin Yu and Jing Sun, our technical lead, and one of our senior methodologists, respectively, who have been behind this very important work. Thank you.
Wow, that's quite an overview. I'm looking at that last slide you had up there, Howard. I hadn't seen that previous, and you know, we're trying to help some of the OHTs and understand where their costs are being attributed. And I think it's just amazing that you're building this transparency. That's really what this is, right? It's just amazing transparency in being able to look at how far into the system. And we've done a little bit of work now starting to see catchment areas of the people who live in your area. And that's kind of what this is getting at, service in your area versus being serviced outside. And there was some work done by the Inspired Research Group to OHTs showing their maps of where their physicians and patients were really in Ontario. And I think looking at those maps starts to get a bit of a sense of where people are that are attributed to OHTs. And so I think, you know, it's a bit, you know, all of costs are not always in providers' control. And so it's about stepping in and saying, these are those things we can really wrap our hands around, and others. You can imagine, I don't know whether you're seeing the chat, but I'm going to bring up some of the chat questions that have come in here. What is not in these costs at present? So I'm just going to open it like there, and then I can poke at all the little ones that have specifically come in. But maybe you could just think about things you know that the ministry, because you do have a view on where the ministry is spending its money in envelopes, that we can and cannot, and that you have been able to put into these costs? And do you have a ballpark on what proportion of health system spending or the proportion of money under the umbrella of OHT providers that you think is in here?
It's a very good question. I don't want to give a specific answer, except I know that, for example, for hospitals, and I didn't mention this in the presentation, but if someone really keen technically will notice that on the slides, some of the proportions from the example I gave and the example in the PDF are slightly off. And that's because when we do the workbooks, they're linking the expenses specifically to patients that we can identify that are attributed to OHT. So there are some costs in hospitals, for example, that we cannot attribute to a specific patient, rather. So they're called non-modeled hospital costs. So those non-model costs are shown in the PDF. So you do have a sense of proportion. It's a small amount, but it's just a significant amount. I think it was about 0.9 million or something like that, or 9 million, I can't remember, in the example I shown. So that's something to you could see that specifically. And then there are areas where we have expense data, but we don't have specific patient information related to it outside of hospitals, for example, CHCs. And so as we collect more data and we're able to attribute to patients, then we'll slowly incorporate more information into the overall expenses that you see.
That's great. And I think, for some where we actually do some tracking, like community health centers, we do some tracking of individual service utilization. It's a matter, I think, of mostly getting the prices correct, and then being able to incorporate those data feeds. For others, such as community health programs, community mental health, it may be, and in fact, actually, there are lots of programs that we provide in the health system that are intended to be sort of public benefit programs, public health campaigns, some of the immunizations, and it's just about getting accessible care to individuals, and not only medical services. Much of what we're hearing in OHT land is that there's other social-based programs that need to be considered. And I think I wouldn't say that OHTs are at a complete loss to use this information, even if they are thinking about those other programs. But maybe, I don't know, Jillian, if you have a view on the ministry's thinking about like support and funding for other non-medical services that aren't, generating bills for government. Do you think they're kind of part of the picture for OHTs as they're planning moving forward towards what you described as the attributable population, fully accountable for health system spending and outcomes?
Yeah, I think it's a great question. It's a big question. I think, as everyone knows, we have required OHTs to include primary care, home and community care, and hospitals within their partners. At the same time, we know that many OHTs, if not all OHTs, are including partners far beyond that. I think that from where we are now into the full sort of vision at maturity of OHTs from a funding perspective, and I said it in the beginning, we're pretty far from that. And I'd say that there are sort of many policy conversations that need to happen between where we are now in that mature state, which includes the idea of what does that sort of integrated funding envelope include, which I think is sort of your question. I think there have been a couple comments in the chat too around upstream services and the opportunity to get information about those services. We're really at the moment working on trying to gain as broad a picture as we can with the information that we have, which is what we've provided to you. We also know that there are gaps in our data that we're working towards. So again, another comment in the chat was around, and as Howard brought up as well, we do not have information and we're not able to attribute patients to CHCs, MPLCs, and AHACs, as well as Indigenous Family Health teams at the moment. However, we are madly working on that, is what I'd say. We do have plans to receive information from CHCs and MPLCs. It will take some time for us, the broader sort of ministry data folks, to work on cleaning up that information and then be able to use it to then attribute appropriately those people to OHTs. Those people have been attributed to an OHT, but it would be based on their access or their use of other services outside of their primary care team. So we know that it's important for us to appropriately attribute people to where they receive their primary care. That's the first step of the attribution methodology. So we're working to do that, to ensure that is as accurate as possible for those people. So the answer to your question is, like, I think over time, obviously, we want to be as extensive as possible with who is supported, with who is included in the OHT, and with ensuring that we have as much information about those providers as possible to help to support all OHTs, to help to support the people that are served by OHTs, and to get a better understanding to be able to plan for future.
Great. And I'm not known for asking the simple questions, so I appreciate your taking on some of the bigger ones. I'm just going to close off with maybe one of a simpler question. Who and how do we get these Excel files? And I know we get these questions because we send out data packages often, and we have one person and we say that your evaluation lead, contact the person who is identified as that. So where do you send these data packages, and how who can access it? So people within the OHTs, because often there are many people and sometimes they don't make it to everybody. Do you know? Maybe someone put in the chat if you don't know individually. So
yeah, I'm fairly certain that every OHT has identified a lead, and that lead would be provided with their data packages through their relationship manager. So every OHT also has a relationship manager at the ministry, and those relationship managers were provided with the data packages for their teams that they have, that they're the relationship management manager for, and those data packages were sent to those folks. It was a year ago now for some, so I'd say if you would like to have access to them, I'd find out who your lead is, or I'd find out who your relationship manager is, or our contact information is easy to find, so just bug one of us. Happy to do that.
Thank you so much, Jillian, for coming today. Thank you, Howard, for taking people through and explaining some of the information. I mean, I had popped into the chat. I think that expand button is like magic. I have never seen such refined data on costs available in the health system. And for OHTs to think, wow, we're actually looking at the entire system for people, albeit with gaps. I mean, I think, our take on considering all of Ministry of Health spending a number of years back was about 75 to 80% of all health system spending went to attributable care. So actually there's 20% out there non-attributable care programs. That was our ballpark estimate. And so it gives people a sense. For folks online, I mean, I say two things. One is medical care is expensive. Maybe we can generate some savings out of medical care, and it's going to go a long way in the other parts of the health system if you can extract it, or start to think about how can you extract it. And I'll come back to that a little bit later on if I get a chance at the end. So big kudos, congratulations to you. It's amazing to have this comprehensive data. Let's not let the perfect be the enemy of the good. This is so helpful and valuable. More information than we've ever had. Let's leverage and use it. Thanks for coming and sharing today. And I'm really looking forward to more of these in the future.
Quite welcome.
That's great. We're going to move on now to a slightly different topic, although very much related. And I'm going to come back up here, and we are going to have our good friend, and fingers crossed I got the right window up here, Dov Klein, is here to share with us some work that he's been leading out of Ontario Health that many of you are hearing about. And so let me turn it over, Dov, to you.
Thanks. Can you hear me?
Perfectly.
Awesome. So hi, everyone. Very happy to be here. Building on what you heard from Howard and Jillian, I thought it would be helpful maybe to share a little bit of some of our thinking around where we want to go and some of our priorities at Ontario Health related to value-based care and what we want to achieve. So if you just go to the next slide, very quickly, we'll take you through these slides. I want to make sure we have time for questions and hopefully discussion. To spend a little time about challenges facing the system, I think it's helpful to start with some context in setting the agenda for this. Talk a little bit of the key trends that are on our mind as we think about our agenda. Talk about measuring value that matters and how we integrate that from a funding perspective, and talk a little bit about key priorities for the coming year. So Walter, if you can go to the next slide, please. So, I think it's important, in any discussion of value-based care, really to take us back to what are the key challenges facing the system from a value-based care perspective. What does it mean from an implementation viewpoint, and how do we move forward? How do we think through these things and manage these things? And I think, it's important to reflect on the fact that many of the challenges related to integrated care and data and funding and outcomes following patients across the health system are not sort of new, right? They existed well before COVID, well before for decades, really. And so heading into the pandemic in particular, I think there were many years of sort of challenges where I think we were making some headway and really thinking about whether it was QBPs or bundle funding or other things that really start to get at sort of how do you manage that patient experience across their episode or experience of care or their entire life. And some of that probably got put on hold with COVID, as many of you can imagine. But I think COVID really gave us a chance to really see these challenges unfold in some ways very spectacular ways, for better and for worse. And so as we move forward, I think it's important to think of sort of three key things that I want to highlight. So as we talk about value-based care and the types of things that we want to focus on, there is going to be tremendous pressure on the system to recover, as you all are aware of and are living, but also containing growth in the shadow of COVID. So we have to get back to where we were from a surgical perspective, as an example, from a primary care perspective. We have to do all this within the shadow of COVID in a rapidly changing environment. I mean, I think I wrote the slide, I don't know, maybe 6 months ago or 5 months ago. I mean, think of just some of the inflationary pressures as an example that the system is going to face. You take a hospital as whether it's $100 million or $50 million hospital or $1 billion+ hospital, if costs are rising at 5 or 6+%, think of the efficiencies, quote unquote, that they would have to achieve just to manage paying for inflationary pressures. Forget about investments in integrated care or digital care or anything else that's required. Just to keep the lights on with those additional costs is a massive pressure. And so the idea that we can do more with less, or just cut, many organizations have 2% strategies, which is a classic way of sort of keeping budgets in line. But those classical cost-cutting approaches don't really work in our new environment, and we really need to think about how to do things differently. HHR is one example. So many of the challenges which are all over the newspapers and will be with us for likely to 2030 and potentially beyond. The other piece which we've heard a little bit about today is around Ontario health teams and funding reform and what that means to how we operate, our framework for how we work together and focus on outcomes. And then really thinking of government being a purchaser of or a commissioner of outcomes versus telling us exactly in the health system how exactly all the little different pieces need to fit together within our silo. Really the government being able to say, here's your population, here are patients that you're in charge of, these are the outcomes we want to see. Now you go away and tell us how you're going to do it. We're not going to tell you how to do it. We're not going to tell you what the method of achieving those outcomes are. And I want to buy that outcome, not just and not tell you how to do it. And then the third area is around innovation enablement and paying for the future of care. And I think that's really important as we, and you'll see this in some of my other slides, as we think about some of the challenges we need to face and overcome, technology is an important component of those things. Innovation, research are all really important ways that will make a more sustainable health system. And if we're not focusing on those things, keeping one eye on what the future comes and how we're going to actually pay for those things, we end up with a stagnant system that's not able to achieve the outcomes that are required. I mean, just think of, everyone talks about, like H. pylori and bleeding ulcers used to cost the system the US system about $5 or $6 billion a year in surgeries that essentially got wiped out through innovation and research discovering that a simple bacteria causes ulcers. And so thinking about how we pay for these things and integrate them into our episodes of care for our patients is going to be critical moving forward. So if you move to the next slide, this is a fairly obvious diagram, but I think it really helps to describe the challenge that we're facing. The fact is a lot of money or a great amount of money sits within the hospital system, as you all know. And the hospital system is also the place that needs to pay for a lot of the innovations for the sustainability of the health system. And one of the challenges of where the investments are made and where a return on investment is found is that the cost of acquiring innovative solutions generally is going to be lower than the full benefits that are seen within the four walls of the hospital. And this is particularly true as we think of true integrated care and where patients do best. And one example, and I used to do a lot of work on HIS and CISs like Epic and Cerner, Meditech, so on and so forth. There is no business case in the world that I'm aware of, and I've seen many of them from across the globe, that will show a positive return on investment within the four walls of the hospital for moving to a Cerner or Epic as an example. Now, you still do it because it's the right thing to do. It's part of being a leading practice health system. But the fact is that the business case never proves out within the four walls of the hospital. It always requires us to expand beyond the four walls of the hospital, look to the full episode of care, continuum of care for that patient to actually see those benefits accrue. And the best example of financial remedies to this is probably Obamacare and meaningful use, where they actually artificially took benefits that were accruing to the system and put it back into the hospital if they can move up the MRAM scale in order to be able to implement CIS of that magnitude. Now that's CIS. Now imagine going lower to all the multitude of investments that are required, whether it's from a general medicine perspective, surgical, whether it's digital or virtual care. There's so many things though that maybe start in the hospital, but then and are paid for in the hospital, but then never get the investment because the business case doesn't pay for itself. Another example is digital pathology. Digital pathology is a no-brainer from a business case perspective when you look at it from a system output, but when you have to pay for it in the four walls of the hospital, very, very, very challenging business case. And so part of what we're trying to do as on Ontario Health is look beyond just silos of the system and where business cases are realized and try to smooth out some of those mismatches as we move forward. The next slide, if you go to the next one, I think the other thing that we need to think about is around paying for solutions versus parts to a process. And we're seeing this happen in the med tech space in particular, where the established companies, and I think it's 7 of 10 of the largest medical device companies in the world, don't consider themselves widget companies anymore. They don't call themselves med tech companies. They call themselves solution companies. They want to be able to align to that outcome that we're trying to achieve to the patient and not be caught up in all the little different bits and pieces that very often come with siloed funding. And so from an OH, from a Ontario Health System perspective, really starting to change our mind of how we want to pay for things is going to be important. My mom had a hip replacement recently, so I got to see that close and up front. Do we want a patient who we pay for the surgery, we pay for all the different things that happen in the OR and the prep beforehand and afterwards, and then figure out the home care components or the physio or the inpatient rehab, so on and so forth, and pay for all those things separately? Or would I rather pay for a patient who leaves on day 2, maybe day 1 or same day, a patient who doesn't show up and emerge with a red or swollen or poor pain control in their hip or knee, a patient who I don't see for a revision, and for 90 days, with excellent proms and prems collected, for 90 days, we don't see that patient. Do I want to pay for that? And I think the answer most of us would say is, yeah, I want to pay for that patient who leaves on day one or same day and who has no problems and is taken care of end to end, versus paying for all the little different pieces of the episode of care. And so that's something that we're thinking a lot about, and something that many jurisdictions are starting to move towards. If you go to the next slide, please. So Ontario has been talking about value-based models for a long time. At the end of the day, I think how we're thinking about it is that, there are classic global solutions to addressing the cost curve, and those are on a long list on the left of all the different things that have been tried, and some work better than others, but comprehensively, they don't all, and individually, they don't work on their own, right? That you need really, and I think the lesson is that you need really a restructuring of how we deliver healthcare and fund healthcare to really get at the root of the problem that those individual things are trying to solve. And so Ontario is moving and has moved from a fee-for-service / global budget type model to starting to think about capitation, as we've talked about, from an OHT perspective, and also from a bundle payment perspective. And I think where we end up is still a policy question, and I think there's more to come on that. But I think the evidence suggests that you probably need some elements of both. With capitation and population-based payments, you get at population risk and population value, which are important things. And those tend to deliver things like better ALC outcomes, shorter lengths of stay, less patients being readmitted to hospital after a surgery, as an example, focusing on reducing variation, improving the cost profile, for example, of high-cost drugs. But that's a population level view and population level outcomes. Bundle payments are important because they also look at the patient level view and the patient level risk, right? So the incentive in capitation and population health type models is focusing on scale. I want to be great at everything. I want to bring as much patients into my model as possible, partially because my risk gets reduced by the more volume that I can manage. We call this actuarial risk. But in bundled payments, we actually get to focus on the individual patient pathway and the individual patient and where risk happens for the patient in a very discrete pathway. And some combination of these two models is likely, my opinion, is where we end up, because I think you get at both. You get at that population level value and risk being managed, but also not taking our eye off the ball on expertise and really focusing on managing that patient end to end. Can you please move to the next slide? So I'm sure many of you are aware of this, but I'll just go over it quickly. Value-based care, which really I think is a combination of what we just talked about, is ultimately defined as the set of outcomes that matter for the condition, and condition doesn't have to be just a 90-day or 180-day pathway. It can be a year of care, as an example. It's a set of outcomes that matter for the condition as defined by the patient, so that's really important, divided by the total cost of delivering those outcomes over the full cycle of care, which again can be a discrete, let's say 90-day pathway, or it can be something that a patient lives with through their lifespan. And I think from an Ontario perspective, it's hard to talk about how exactly this works and make it fit exactly within this equation. But I think it's a good way for us to be able to have a conversation of how we start to think about implementing these things in a meaningful way. If you can go to the next slide. So actually, let's just go on the next slide. I think I kind of covered this. In an OHT perspective, what we're trying to now do is really think about how we actually think about pathways and value-based care in very discrete pieces of work. So this isn't saying this is the final model, or this is how OHTs are going to be funded at the end of the day, end to end. But we do know that we need to be able to focus on clinical pathways and implementing them in a meaningful way. And what we're trying to do is focus on areas where we think we're going to get best bang for our buck for patients, and where the need is the greatest in terms of creating that end-to-end experience. And CHF is a great example where we really try to come up with, through an OHT context, a way to deliver that end-to-end pathway. And so as noted, maybe as noted earlier, but I'll just touch on it again, right? When we're talking about a pathway, we're talking about the end-to-end experience for that patient, from screening or diagnosis all the way through end of life, and all the things that happen to them and all the costs and interactions with the health system in order to deliver that. And CHF is a good example of something that doesn't have an end, right? When someone's diagnosed with CHF, it's not a 90-day pathway. It's something they're likely going to live with for the rest of their life. And figuring out how we develop a risk-adjusted approach to implementing CHF is the goal. And what we did earlier this year was announce a demonstration approach to CHF for OHTs that would provide seed money to the OHT to be able to integrate the entire pathway and bring all the different partners to the system, and also make some investments, for example, in digital and virtual care and some HR as well, but also give QBP protection. So CHF, as many of you know, are QBP, to give QBP protection to the hospital, that if they actually implement the pathway end to end and do see a reduction in inpatient admissions, that there's no untoward consequences that might happen to the hospital's budget. And so what's interesting, and I think what we found, is that while patients will go through the pathway that you see here on the right, all the way from a community and outpatient setting down to confirmed heart failure, what we're seeing is that many of the providers who are starting this work are setting up models that actually support primary care and community care in managing those patients in the most appropriate setting, which is generally going to be in a primary care setting or at home. And so they have confirmed heart failure. But for example, if they need their medication titrated, very often patients will then be turfed to the hospital or to the advanced heart failure clinic within a hospital. But if we put the right supports in the hospital, virtually, like for example, an advanced practice nurse, primary care and community care can manage those patients without them coming into the hospital. And in one hospital in Ontario that implemented this model that Core Health had put out, they actually saw almost a 30% reduction in readmissions for CHF just by implementing this best practice pathway. So that's an example of what we think will be hopefully one of the core work for an OHT, in really being able to set up that end-to-end pathway for patients and bring the right resources and HSPs to bear to do this. If you move to the next slide. So our commitment when we take on a pathway is really threefold. So I think, this isn't to be critical. I think it's just a fact. If you look at the history of transformation in Ontario, very often we'll focus on clinical evidence or clinical pathway, or we'll focus on funding transformation, or we'll focus on enabling technologies and supporting some of those technologies. But very rarely do we actually focus on all three of those things at the same time. And so whether it's CHF or COPD or others that we'll be implementing in the coming months and years, our focus is to actually focus on all three of those things so you get sustainable system transformation. One example, population health, which is the division within Ontario Health that I work in, we spend $10 to $50 million a year approximately on seed funding for digital and virtual tools for heart failure. But yet we never look at the funding model or the clinical model that would support those in a sustainable way. So we give money to the system. It's good money, it's seed money, it does good things for patients, but as soon as the seed money disappears, we have never actually addressed the underlying funding model to support the full episode that's required for that patient. And so that's our commitment moving forward, is to actually focus on all those three things to make sure that we're doing this in a sustainable way. In terms of the things that we're going to focus on, these 6 things by no means are set in stone or comprehensive, but I do think it gives us a certain sense of where we might want to focus from an implementability perspective. So conditions or pathways that have a growing prevalence in the system, have high acute care utilization, have evidence that they can be better managed in the community. And this is really important. If we don't have some consensus or leading practice approaches to say this can be done in a community or OHT type setting, and this is how you would do it, it's really hard to be able to get momentum to move forward. 4 is around having strong provincial and local clinical leadership. And so, for example, Core Health recently put out not just their CHF best practice pathway from an integrated care perspective, but also for lower limb preservation, which we're one of the worst performers in lower limb loss in the developed world. By having that strong provincial and local leadership that wants to do this and needs to do it in as soon as possible is going to be really important. 5 is having clearly identified sources of funding. So for example, CHF, one of the ways that I think we were able to move it quickly through the system is because it was already carved out of global funding. We already kind of knew not all the dollars for the entire pathway, but at least some money that we could target and look at and say, hey, if you can take this money, extend it, we'll make sure that we can guarantee it and make sure that nothing untoward happens. That makes the conversation easier about how we fund some of this stuff on top of additional seed funding. And then 6 was a robust measurement and evaluation framework. And so these 6 things I think will guide us from an implementability perspective in which pathways we're going to focus on moving forward through OHTs. Last slide, I think it's my last slide. So key priorities for my team moving forward, unlocking funding to support integration. We talked about CHF a little bit already, but really being able to think about where is money locked into the system that we can be liberated and unlocked so it can be used in non-acute settings is the first one. Moving from left to right is creating data structures and reporting to enable OHTs. So many of you will have seen the BI tool solution that we've now put out in collaboration with Jillian's team to be able to provide local level data for OHTs from both an attribution and a geographic perspective. The principle being that while you may be funded or organize yourself from an attribution model perspective, we deliver health services generally in geographies and through communities. And so being able to show both those views is part of the solution. And over the next 12 months, our goal really is to take all the massive data that we have within OH and be able to start giving it to you at a local level to help you in planning for the future. The third area is around supporting performance measurement accountability for integrated care, working with the ministry and with Jillian's team and with other parts of the ministry to really start thinking about performance accountability, quality, governance, so on and so forth for OHTs moving forward. And then the last area is around analyzing system investments based on value-based care principles. And that's really what I mentioned earlier about how do we pay for the future of care? How do we stop looking at, maybe the 12-month budget cycle that we make procurement decisions on for certain medical technologies and really think about what's the impact of that technology to that patient over their lifespan, and really being able to think of that full cycle of patient care that's required and think of the value that's created relative to the decisions that are made on particularly digital health and surgical type technologies. And that's that. Happy to answer any questions and discuss further. I hope I didn't go over, Walter.
No, it's absolutely amazing. I think actually your content, and just to speak to everyone's interest in this, this is a nice summer warm day. We've had up to 200 people on this call today, watching in and listening, and I think we're still over 170. So sometimes at that 1 hour mark, some people need to go to meetings, but we're still really high. We only lost like a few people. There are a couple of questions coming in, and I think I want to get to them. I want to, as people are thinking, I also want to pop up a little poll for folks, and just to get a little bit of a pulse on how much people are thinking about this space, and so how much people are thinking about integrated payment. So has your OHT begun to think? And if you're not in an OHT but you're supporting OHTs, answer it from that perspective. Either totally implementing integrated payments, starting to plan for that integration, maybe having discussed but perhaps feeling unable to develop those plans, or not having discussed it yet. So chime in and let us know sort of where you're at in your thinking, in your planning, whether it's been on the radar. We know we're a little bit ahead of the curve here, and we're going to continue to push that envelope. I think we need to reorient, and there was one of the chat comments earlier, I'll come back to it, I think, is thinking about, Anne Wojtek had said, cost challenges can't quite shift from hospital to community because there isn't enough capacity yet in the community. So we need to, and we're a little bit ahead of all of that capacity, I think, still in this context too. So being aware of that. I think we have, it's slowing down, so I think we got most of the people that are going to chime in for this. So out here, just sharing the results out, 2% say they're actually at that space of implementing payments. 6% in that planning. And then we see, you know, starting to generate a discussion about a third of folks and 2/3 of folks. It hasn't yet been on that radar of discussion, but I think we're introducing it here. Ontario Health has been introducing it along the way, and you're going to see a lot more of this. I think Dove has clearly signaled that in this context. So thanks for that. And I've got one other question, and we can think about the chat, and that's like, what kinds of care do you want to provide that would be enabled? So this is really an audience question. I'll pop it up on the screen so people can see it, and then I'd like to see some chat around this. And then Deb will come back to questions with you. And that is this question here. Using the chat, what kinds of care do you want to provide that would be enabled by integrated payment? Let's have a bit of that discussion, thinking about that. Meantime, I can come back, Dove. You know, I'll come to some of the questions. Yeah, I think one of the questions from El Mustafa Buatane, I'm not sure I'm saying that quite correctly, but brought in here and said, you know, value-based funding models, and they're very innovative, but they should really be looked at from a radical change and focus on primary prevention and population health. So my question, Dove, is how do we help OHTs and others in the system, everybody in the system, think about incrementalism, shifting piece by piece and bit by bit versus just, you know, radical upheaval, and just get away from the sickness-based system that, you know, largely we've developed to more of a prevention, management, control, chronic health supporting and enabling systems.
Yeah, so I don't know if radical incrementalism is the right word, or it's somewhere in the middle between incrementalism and the radical change that we're talking about. Listen, you know, CHF was where we started, and we started because there was a lot of momentum within the clinical world to start managing this. And I think if you talk to many hospitals and their advanced heart failure clinics in particular, what you're hearing and what we hear is that even if you don't do value-based care and you don't do integrated payment models, the current system just can't manage, right? If you look, you know, I've named several hospitals, but I'm thinking of one in particular where they kind of said to us, they're like, our patient population is aging at such a rate that, like, we're going to do integrated care for heart failure patients, even if you guys do nothing, because we literally can't be the one-stop shop where every patient gets turfed to be managed, you know, in a more integrated way. And so needing to be able to make the investments downstream, and particularly in primary care, to manage these patients more effectively and provide them with the confidence, the tools, the resources to actually manage those patients in an effective way is required to just keep the lights on. And so I think we're at a point where you know, even if we did nothing, these are the conversations and things that would start to happen regardless. I think lower limb preservation is another great example, where there are vascular programs and local health systems which are getting together to figure out, like, how do we do a better job, even with no direction from the government, because we can't keep on chopping off people's toes and feet and legs. And so I think the common denominator here is that what we're really talking about are generally going to be things which are chronic in nature. Christensen at Harvard calls it a facilitated network, which is essentially a changing consortium of people and health services providers who need to manage patients, where the warm handoffs and the integration of patients and the data related to those patients is the work to be done. It's not a 90-day pathway. It's not a 180-day pathway. It is the life of that patient. And so I think what you're seeing from my comments, but also from, I guess, my answer to this question, is that where we really want to focus on, where we think we're going to have the biggest bang for our buck, is focusing on places where we can take money, move it upstream, and start to be able to enable a more health system approach to managing these patients in an integrated way. And you know, Walter and I have talked about this previously, right? CHF patients don't only have CHF, they have COPD. They also have diabetes. They also very likely could be a patient who's a candidate for lower limb loss. And so by choosing some of these pathways and looking at the money associated with them that are already in the system, you can start to see the beginnings of a chronic disease management program, right? That if we give you the money for CHF, we give you the money for COPD, and this is, again, just a thought experiment at this point, you can imagine having a bit of a scalable approach to being able to now manage these patients with real dollars to play with across the system. So, would I love to just, press a button and suddenly everything is integrated and funding flows perfectly across providers? Sure. But the reality is we have the system that we built, and what we're trying to do is thread the needle through many of the constraints to build hopefully something that's better. And then I think success begets success. If we're successful in CHF or successful in some of these other chronic disease pathways, it really lays the groundwork for more investment and more integration.
Okay.
Sorry, that was a long answer.
No, that's great. I think we're coming close on time, and so I'm going to ask, my easy question of the day. The one that's going to be summed up real fast. You mentioned, and I think we saw with other data that lots of the costs are in the hospital system, but decisions about that spending and who is using the hospitals and what they're using in there are most often made by physicians. Most of the decision making on those, and physicians want to be able to identify the best care pathways for their patients, get them access to the best care without needing necessarily to consider cost. I think that's not to say no physician cares about cost, but they want the best decisions, and that's the primary thing, is that quality of care. Do you have ideas? We don't really have physicians very well integrated into other healthcare. In fact, the funding that flows in the healthcare system is for physicians and for pharmacy actually sits outside of the buckets of all the rest of the healthcare dollars in the system. That's true across Canada. Someone was asking me, maybe we could adopt Australia's system. I'm like, actually they got the same problem. I would ask, how could we do better? And do you have ideas? And there might be some ministry people who do or do not want to blade, into this foray of physician engagement in these funding models. Certainly when we've seen exemplar models of integrated funding, be they episode-based or full community-based capitation-oriented models like bundled care in the Netherlands, physicians are included. What do you think?
Do you want me to take a stab at that first?
Well, why don't you take a stab at it, and maybe Jillian and Howard will have something to say, or maybe they want to stay on mute.
Yeah, Walter, so I'll say it in maybe even harsher terms. I don't believe there is a example of successful value-based care or bundled care model in the world where physician compensation is not somehow included in the model. So maybe that's maybe a more stark way to describe the problem or the opportunity that we're facing. And I think I don't think at this point I'm in the right position to be able to say, this is what exactly we need to do with physician compensation moving forward. I think it's an incredibly complex issue related to value-based care. However, I think through our engagement with the system and through our clinical institutes, where we have strong physician leadership and engagement in improving the system, I think we still move the needle. And I think, again, heart failure would be a good example. I think the early work on lower limb now is a good example where it's very often physician-led in terms of not just identifying the problem, but saying, let's not worry about compensation. Let's just worry about doing better for our patients. No one wants to do substandard care. No one wants to be having patients coming in with an exacerbation of heart failure when they really should have just been managed in the community, or having God forbid a limb chopped off because there was just a lack of integration. And so I think we're seeing, and I mentioned this earlier, I think we're seeing, independent of the funding model, in certain areas, physicians coming to the table to really help us in identifying what's the best practice pathway. Maybe at a high level with regional variability has to be taken into account, but really to set the boundaries of what good integrated care should look like, again, independent of the funding. And so it's our job, as I mentioned earlier in that little triangle, to start these things and get some momentum, get patients doing better, and then look at the broader funding model issues over a period of time.
Okay, thank you for being stark. I was trying to edge into it nicely, and I'm glad you just came out and just called it what it is. And I'm actually going to then, bounce off you a little bit and say, until we have physician payment included in these models, we will not be entirely successful. And I will also say, so until you have integrated funding, you're not going to have integrated care, and until you have integrated data, you're not going to have integrated care. So I'll let it off there. I'm going to let Jillian and Howard off the hook because I got a couple things I just want to bring up for folks. There are some really interesting chat comments in here that we didn't get to yet. Colleen Neal talking about ANHP, about a physician group and a wholly new thinking around alternate funding and capitation or composition model she referred to. Other ideas, we did ask for some suggestions, and we're going to take this back, and I'll make sure that our everyone participating in this webinar has access to these. Some of them are actually specific questions that we'll endeavor to answer for you in the meantime, because I do see that it's been quite active, and there's some interesting suggestions, and I think a lot of support and movement. Certainly, I'm seeing a lot of refrain. I'm seeing a lot of primary care mentioned. I'm seeing a lot of community-oriented care mentioned in these points. So I think at least the people that are online here today are quite keen to move this ahead. So how do we support that? And there's some questions very specifically about who at the ministry can they talk to, or from Ontario Health about implementing some novel models of care. And Kirk O'Connell, I saw earlier, saying we can't just keep funding things the same way and expecting different results in slightly different terms. So we need to keep this incremental marginal piece always moving. Okay, we've talked a lot about things today, and I just want to remind people about some of the topics that we talked about today might have seemed new and novel, but actually a lot of them have been mentioned in prior webinars. We've been building towards this kind of activity all the way along. So back in September of 2021, you might want to go back and have a look there. We had Deb from ChiHi talk to us about these HPG categories and how the whole grouper is put together, so you can help to understand better the data that's coming to you in the cost packages. And these were the costs that went into the ChiHi POP grouping methodology. So you can go back and have a look and get some explanations from ChiHi itself. And they also have some online materials. In that same webinar, BC talked about how they're using the HPGs, and this is into all of their, and this is from BC, the number of individuals and how much they were spending on average for people according to these different groupers. So, we're not alone in doing this. ChiHi supporting work across Canada. Again, that was from that September webinar. In January 2022, Holly Opera and Darren Gershon were here telling us about how they're using data around the HPGs and costs. And this is using IntelliHealth data. And I think there are some really interesting, novel, new additions, enhancements to IntelliHealth for Ontario Health teams that will be useful in the future. And I saw Holly online today, so I had checked in. So they looked specifically at some of these and thinking about this year's costs and next year's costs around helping to target their work. So that was from January. You might want to go back and have a look at that one. We've been doing this work for, as I said, well over a decade. We had a working paper that we developed back in 2013 and produced based on what we had already done about how do you think about person level costing. And so I'm just going to highlight a couple pieces around there. Is one for you to think about if you're trying to develop costing or use it. Some things are like claims encounter based, like physician payments per visit. We also have capitation, so keep that in mind. Drug benefits, services, supplies, things like that. We have shorter based episodes like acute, inpatient mental health. And then you have longer term episodes, complex continuing care, institutional long-term care. And, you might decide that home care is actually service-based or it's longer episode-based. Depending on the target population, it may actually fit into multiple spots. So thinking about this, you can read that guideline that's available online and have a sense of how do you think about it. Other thing I wanted to mention is population segmentation. So we looked and heard from Howard on the population segmentation with the ChiHi grouper. There were 239 groups, I think it was, HPGs, and then the 16 categories. And then we also have, there's not only one grouper, so we had other ways of looking at it. One of the ways we went out to 46 OHTs to review CQIP indicators, and we did also share some cost results at the time on the BC Health System Matrix, which is another way of thinking about populations. And so we had said, if we go to a pyramid and a population health approach, think about the entire segments, you have high users, medically complex, that kind of risk tower from Kaiser Permanente. And we had looked and identified the per person per month alive costs according to these different categories: people at the end of life, people in long-term care, people with high chronic care needs and frailty in the community, cancer patients. So again, it's this orientation towards population groups, and then thinking about the entire health system cost. And so we're not thinking about how much does it cost to treat diabetes in a hospital. We're thinking about how much do we spend to care for people with diabetes in the health system. That's, I think, the fundamental change that we've been supporting for many years. And you can go back, we've got lots of work on this in the past. This is, every OHT has this table. We've produced the cost results according to the 16 groupers. We didn't do it for all 239. You have that from the ministry, but cost and also premature mortality. We've actually produced all of our 25 indicators plus the CQIP indicators according to these segments. So not only can you have the cost data from the ministry, but you can also look to see how you perform on things like readmissions to hospital, physician continuity of care, home and community care services, how frail older adults are managed, their functional status improvements, how are we doing for mental health patients, what are we doing on the CQIP indicators according to all of these. And you can think about that, those performance gaps, and also then your comparative cost gaps. You have your own cost, and the provincial costs, which is the figure that's here, is available on our landing page on our website. So you can make those kinds of comparisons. I think just building on some of the work that you've seen here today. We also think that you should be thinking about equity. We are always thinking about equity. And we have different ways of thinking about equity. Last month, we had proms and prems, and we showed things according to ethnicity, age, race, and particularly income, housing, and food insecurity, as well as social isolation. And we showed proms and prems were, very much impacted by some of those social determinants of health. Here we have overall thinking around the entire material deprivation. This is an aggregate and area level, so where patients are living. And this, for example, is the risk adjusted. This is age, sex adjusted costs across the OHTs, cost per month alive, according to the OHT. So you see, a fair bit of variability in total system costs from like just under 250 per person per month to well up nearing $400 per person per month in terms of total expenditures. The colors here map to the area, the proportion of the population living in the most versus the least deprived areas, according to the quintile across OHTs. So the OHTs with the most individuals in high areas of deprivation are the darkest blue, and the ones with the most in the light, in the least deprived areas are in the light. So having a look at some of these, this is across OHTs. You also have data within OHTs, so you can actually look for each of the populations, what you're spending on individuals with each of these grouping conditions according to where people live. And so you can see overall, generally speaking, people who are in the highest area of deprivation, Q5, we spend more money on. It's about 40% more overall compared to the people who are in the least deprived areas. There's a reason for that spending. People are not well. And if you look, major mental health, that is not true, but all through all of the other conditions, we actually see that we're spending more in the individuals who are living in areas of high deprivation. The fact that we're not doing that for major mental health makes me wonder, because I do think that the prevalence of mental health is probably at least, if not higher, in those areas of deprivation. So actually that may actually represent an underspend as opposed to a more equitable spend in that case. Remember, we're not trying to make things equal, we're trying to make them equitable. So some of the things, and those are all just data points that you have currently. I'm just going to close off now. We've been ranking the OHTs by performance and using color coding with the OHTs remaining anonymous, flagging again for people. We are aiming to create peer groupings, and I'm going to ask you one more question here today about peer groupings. So a poll coming up next, and we are going to start identifying the OHTs in all of our reporting going forward. So here's the poll. What factors makes another OHT comparable to your OHT in terms of total cost? So this is really thinking about everything that you do to care for your populations. What is it that makes them more or less, there we go. So tell us, what things more or less in terms of your overall aggregate health spending. And so if you could click in, you can click in as many of these as you think are really important. We're starting to think about things that we should be thinking about in terms of grouping for total cost as well as others. So the polls are coming in. Okay, they're slowing down a little bit. We'll leave it up for just a few more seconds here. And 3, 2, 1, people have gotten quite good about this. So I'm just going to share this out now. And you see, interestingly, and I think we saw this in some of the chat comments about, where you are geographically having a lot to do with how much you're spending. That has a lot to do with how many services are available and also the cost of rendering those services, I think. Material deprivation being key, and then we see a few others. I'm going to have to, I think, extend, just a tiny bit, and you might have to scroll down to see the others. Some other people saying some other considerations, so maybe have a look over in the chat to add those last few little comments. Okay. I really appreciate everyone being here. I'm so appreciative to our guests today. I think we had a very enlightening, we had a great audience for the end of July, just absolutely amazing. We are going to take a hiatus for August, give everybody a break, ourselves included. We'll be back in September with the results from the Ontario Organizing for Ontario Health Team Survey of Leadership and Ontario Health Teams. October 22nd, we are going to start having concurrent joint events with other lead organizations. We're going to start with the International Foundation for Integrated Care Canada, IFIC Canada. We did one of these in June 2021, and it was a big hit. We had over 600 people online, and it was around evaluation. We're looking at very innovative topics in the year ahead. We're going to start doing these on a semi-regular basis. So check out September, check out October. And, we do this, and I will say, we have 200 to 300 people online every month, and about 3 or 4 people click into the box that we put in the little chat, the little link where we say, could you give us some feedback? And, we send out a survey the next day. And I appreciate that everyone's not going to take the time to give us feedback and let us know how we're doing. The fact that people keep coming back, I think, will take as a sign that we're not doing a terrible job. But it would be absolutely amazing if people could take a minute and this would be a QR code. You can do this on your phone. There's only 3 questions, and give us a little bit of feedback on how you think this went. Reminding you about our team and thanking you to keep following us. We have the webinars coming up, and we'll have more work coming forward in the coming year. It's been a real pleasure to be working with all of you, and thanks for coming. Thanks for your chat. Thanks for your comments. Really, really, really happy to have all of you here today. Take care and enjoy the rest of your week, and enjoy your August. Hopefully everybody's getting a little bit of time for some family, some downtime, some maybe going to places like this over my shoulder view today. Take care. Bye-bye.